so weak lung muscles. Head injuries can cause this. Sedatives, narcotics, so a decreased respiratory rate, so maybe they're like getting a little over sedated from the medications they're on. Atelectasis, decreased depth of respiration, so now we're trapping CO2 in the lungs. Obstructed airway, and inappropriate ventilator settings. And that's why we do ABGs on ventilator patients every morning, because it might tell us like, oh, maybe we got this patient breathing too slow. Maybe they need to be at a faster rate. They're starting to get a little acidotic. So that's how the doctors kind of evaluate what their ventilator settings need to be at. Causes of respiratory alkalosis, anxiety, fear, fever, hypoxia, and inappropriate ventilator settings. So that's just a patient who maybe is breathing like they're hyperventilating, and you can hyperventilate yourself into not feeling very good. You can get to respiratory alkalosis because you're breathing off too much CO2. So that's why we got to calm those patients down. There is a reason why you shouldn't be breathing too fast. So sometimes when patients start doing that, you got to be like, okay, put your head between your knees, calm down. You actually cannot breathe like that forever. Causes of metabolic acidosis, so that's a gain of acid. Renal failure, lactic acid production. So I think of like, oh, you exercise a lot and then your muscles hurt really bad because you produce some lactic acid. But it also applies to septic shock patients. So that's why you might get metabolic acidosis in your little septic patients, because they're producing this acid now. Diabetic ketoacidosis, overdose of salicylates and some methyl alcohol. And then loss of base, so loss of pancreatic juices. Maybe they have a pancreas transplant or something like that. And then, of course, diarrhea, because you also lose base with diarrhea. Causes of metabolic alkalosis, so loss of acid. NG suction, like I mentioned earlier, we can just suction all that acid out of their stomach, but now we've thrown off their internal balance. Vomiting, diuretic therapy, gain of base, so aldosteronism, which is an overproduction of hormone causing hypertension, unresponsive to medication, and low potassium. And then antacid administration, so those people that are popping the Tums all the time, they can be throwing off their internal balance as well. And then you can do more ABG practice. I just went on this website this morning. They have ABG practice, and I think they had like EKG practice as well. So that might be worth visiting a couple of days before you go sit for your test. Tuberculosis, resurgent in the U.S. unfortunately. This is a reportable disease, so we have to report it to the CDC. We're going to talk about the medications you need to take. We'll need to have sputum tests done repeatedly, since they are considered infectious until negative sputum cultures are collected. Proteins should be high in protein and carbohydrates. So rampafin is an antibiotic, and that's one of the antibiotics they might take. There's actually a whole class of drugs that you can review of what they all take. You're going to be taking a combination of antibiotics probably. The INH, the danger with INH is that it can cause severe or fatal liver disease, so it is a dangerous drug. It's hard on the body, but it eliminates the active growing bacteria. The problem with TB is that the bacteria can exist in a resting, non-growing form for long periods of time. So this therapy and the other drug therapy, that's why they're on it for like 6 to 12 months, because they might have sputums come back negative, but if they're still showing chest x-rays or still not clear, the bacteria might just not be growing. But you need to be taking this because we don't know what periods of times when it's not growing, when it is growing. So these meds have side effects that a lot of people may not want to take them, but there are reasons why we have to take them for such a long period of time. This is a hard disease to fight. And then ethobuterol is an antibacterial agent, works by stopping the growth of the TB cells, which results in cell death. So those are just different classes of the drugs. But a lot of these people are going to be on like 4 to 5 antibiotics. They're going to be on the INH. They're going to be on the ethobuterol. So, I mean, they got a rough road ahead of them. And of course, it's not really a choice. You have to take these medications. So if you get a non-compliant patient, that has to be reported, okay? This is a highly contagious disease, and we got to make sure, we don't want to spread it to people in the community. What are some classic signs and symptoms of TB? Night sweats. That's one of the most classic signs. You get the night sweats. What?
Weight loss.
Yeah, weight loss.
Coughing up blood.
Coughing up blood. Cough with blood-tinged sputum is common, and fevers are also common for these people. What advice should you give to a patient who is on oral birth control and is also taking INH? It's probably pretty obvious. INH makes oral birth control less effective, so we just need to counsel any women who are taking oral birth control that they might need to use an alternative form of birth control while they're on that medication. Why are clients often prescribed at least 2 drugs for the treatment of TB? It's because we have multiple multi-drug resistant strains of TB, so we got to hit them from a lot of sides with the antibiotic therapy. 4 antibiotics is not uncommon for these people. And then, what are some common extrapulmonary TB sites? So the brain, we might see that. Meningitis, you might also see it in bone, lymph node, larynx, and kidneys. What constitutes a positive TB test? This one is I'm going to say, this one's a little complicated because we obviously do the, the skin TB test, but different sizes of the wheel means different things for different patients. So a 5 millimeter or more is positive in patients with like HIV, persons who have had contact with TB people, persons with nodular or fiber optic changes to their chest x-rays, patients who have organ transplants, and other immunosuppressed patients. So they don't need as big as wheel as maybe someone like me who doesn't have any conditions that would make me immunosuppressed, but that small of a wheel may indicate TB, so then we got to investigate more. A 10 millimeter or more is positive in recent arrivals, less than 5 years from high prevalence countries, people who use IV drugs, inject drugs, residents and employees of high-risk congregate settings, so like prisons, nursing homes, hospitals. So, I myself work in a hospital, so I may fit in this category because I am an employee of one of these high congregate settings, okay? Microbiology lab personnel, people who might work with TB bacteria in a lab. People with clinical conditions that put them at high risk, so people with like diabetes, prolonged steroid therapy, they're immunosuppressed, leukemia, end-stage renal disease, anything like that. And then children less than 4 years of age, or children and adolescents exposed to adults in a high-risk category. And then 15 millimeter or more is positives in persons with no known risk factors for TB. So you might have to, if you do TB skin test, you might have to get, once you're reading them, you have to get more in depth in the history of the person that you're reading this on to identify if there's somebody who we need further studies on to see. Of course, we don't ever say you have TB just with the TB skin test. There's more involved in diagnosis with someone with TB, but that's just the first step.
They're using lab tests now.
Are they?
Yeah.
I had not heard that.
Yeah.
Well, that would be a lot easier then. Just do a lab test. Is it like the T spot? Is that the T?
I don't know. When I came That is for somebody to.
Yeah, because for school I've been giving blood instead of doing the TB skin test. I think they call it the T-spot test. So yeah, that's probably more easier to read than a skin wheel, because then you have to go more in depth in it, whereas the T-spot probably will tell you yes or no. But they don't update these tests every year, so just know, some of these questions might be from a couple years ago. Okay. Lung cancer. Most important thing we can do for lung cancer is to prevent lung cancer. So because treatments can sometimes, they're not very responsive to treatments, or they're very harsh treatments. A lot of times symptoms may present only in later stages of the disease. And then some treatments include the lobectomy, where you have one lobe of the lung removed, or a pneumonectomy, which is full lung removal. Lung cancers are classified into two categories. The small cell carcinomas make up to 15 to 20%, and then the non-small cell carcinomas make up 80% of these cancer cases. The non-small cell carcinomas include squamous cell carcinoma, large cell carcinoma, and adenocarcinoma. Up to 40% of your lung cancers are metastatic. And then the common risk factors are, of course, cigarette smoking, environmental factors such as air pollution, genetic factors, and occupational exposure to carcinogens can also cause it. If you don't know a lot about lung cancer, some of you might work on a cancer unit here, it might just be useful to review the different kinds of lung cancers. They each have their own characteristics, so they might ask you questions about like how you would teach a patient, which is the example I have coming up, but like how you would teach a patient when you know their specific kind of lung cancer. So it's good to know maybe just the basics. I wouldn't go too in depth, because again, there's mountains of information on lung cancer, of course, but you may just want to be able to recognize the different types of lung cancer and to identify maybe the most prevalent ones and the ones that are maybe most dangerous. So like adenocarcinoma, characteristic of that, it tends to grow slowly and is peripheral located, and it spreads early to regional lymph nodes. Large cell carcinomas, those produce large necrotic masses that grow rapidly, metastasize early, and spreads extensively. Small cell carcinomas, you can put a star by that, is the most aggressive lung cancer, tends to grow very rapidly, and is centrally located. Metastasizes through lymph and blood system, but it responds to chemotherapy. Squamous cell carcinoma is the most common lung cancer, tends to grow slowly, and is centrally located. It produces early local symptoms, tends to cavernate, and metastasizes to intrathoracic sites first. Some lung cancers are asymptomatic, and you might only notice it when the cancer metastasizes to other body systems, and then those symptoms start to show up. So that's why it's important to prevent, because it may take a while to diagnose this. So we just kind of said, what is the most aggressive lung cancer that rapidly spreads but responds to chemo? Yeah. Is surgery usually recommended for this cancer? And I'll just tell you, no, because it's most likely already spread before you diagnose it. Obviously, everybody's treatment is going to be a little different, but it does respond to chemotherapy. Name the 4 areas or organs that commonly spread to the lungs. So these might be kind of hard to know if you're not an oncology nurse. Bladder, breast, colon, kidneys, prostate, and neuroblastoma. So this review question: a nurse is preparing to reinforce the teaching plan for a patient who has recently been diagnosed with squamous cell carcinoma of the left lung. Which statement by the nurse is correct?